So I'm going to give an update on the anti-seizure medication use and focusing on acute symptomatic seizures and seizure emergencies. I have no relevant disclosures, and I will be briefly talking about intranasal benzodiazepines for prolonged seizures. Our objectives today, we're going to describe controversies and updates in the management of acute symptomatic seizures, review the current landscape regarding the treatment of convulsive status epilepticus, provide an updated algorithm in the diagnosis and management of non-convulsive status epilepticus, and then we are going to discuss the variability in defining seizure clusters and discuss some management strategies. This is our agenda, so we're going to start with acute symptomatic seizures. So obviously we have to define acute symptomatic seizures before we're going to dive into treatment. So there are variable definitions that are used regarding acute symptomatic seizures depending on the etiology. So when, in general, when we consider acute symptomatic seizures, they would be seizures that are provoked, but they occur in close temporal proximity to a potential cause. More specifically, if you're talking about TBI or stroke, it's usually going to be within 7 days of that event or injury. Usually when we think about severe metabolic disturbances that can cause acute symptomatic seizures, we're going to look for seizures that are provoked within 24 hours of that metabolic disturbance occurring. And then any other condition that would have ongoing potential risk for seizures over a period of days or even weeks, including autoimmune encephalitis or ICANS from CAR T-cell therapy, would still warrant the diagnosis of acute symptomatic seizures even if you're past that 7-day window. We also want to consider the fact that these are different from epilepsy, and this is why we want to define them, because treatment's going to be different. So when we look at epilepsy, these are obviously going to be unprovoked seizures, and technically the definition would be 2 seizures that are unprovoked that occur spread apart by 24 hours, though now we obviously know that patients can have 1 unprovoked seizure, and if there's an evaluation that would uncover a potential cause that would increase the risk of seizures in the future, this would also warrant the diagnosis, and that cutoff number is 60%, which we want to keep in mind when we think about particularly treating acute symptomatic seizures with long-term therapy. Now, why it's important, a couple of reasons, obviously. Acute symptomatic seizures are pretty common, so they make up about 30 to 40% of epileptic seizures that occur. There's a lifetime risk of about 3.6% in the population, and we now know, obviously, with recent studies that we're using more continuous EEG monitoring and discovering and diagnosing more subtle and non-convulsive seizures in this setting. So you'll see more studies and more papers coming out regarding this topic because of that. Now, there are a lot of different causes, as we all know. They can be primary neurological causes or systemic causes that we have to keep in mind. And why it's important to think about the etiology is for a few reasons. Number one, the pathophysiology is going to be different, obviously, and this will determine the risk of ongoing seizures in the long term. So with acute ischemic strokes, they're going to have acute biochemical changes that are going to lead to an increase in excitatory neurotransmitters that will ultimately lead to neuronal hyperexcitability. When we think about sepsis or toxic metabolic causes, a diagram on the right would be an example of ICANS and its association with acute seizures. This is related to a couple of different possibilities, one of which being that there could be a release of pro-inflammatory cytokines that could traverse the blood-brain barrier and lead to neuronal hyperexcitability. When we have electrolyte imbalances from severe metabolic disturbances, this can cause altered ion gradients and subsequently secondary neuronal hyperexcitability and seizures. Now, obviously it's important because we know that patients with acute symptomatic seizures in both short-term and long-term study do have worse outcomes when compared to patients with similar pathologies. We also know that even though it doesn't meet the diagnosis regarding the criteria for epilepsy, that patients who have acute symptomatic seizures related to a specific underlying etiology do have a higher risk of seizures in long-term follow-up when compared to patients who do not have seizures from that same etiology. However, the problem relates to the fact that there's variable degrees of risk for recurrent seizures. We know that it's related to the etiology, so you can see that examples would be viral encephalitis, where you're kind of getting close to that 60% cutoff regarding the diagnosis of epilepsy in terms of long-term follow-up and risk of recurrent seizures. Other etiologies have less association with recurrent seizures, as you can see, but variable numbers. You can see anywhere from 2 to 15% with TBI, and ischemic stroke anywhere from 3% up to 33% of cases have recurrent seizures. The one thing that's been consistently shown in these studies is that having a structural lesion is associated with a higher risk of recurrent seizures in long-term follow-up. Something that we want to keep in mind when we review these studies. So I think really what it comes down to, and this obviously is talks related to anti-seizure medication use, is how do we approach when to start, when to continue, and when to stop treatment. And that's one question we have to ask ourselves. And then the other question would be, what's the importance of EEG, and particularly diagnosing clinical and subclinical seizures in the acute setting and how that pertains to the risk of ongoing seizures in the long term, and then determining how we're going to use anti-seizure medications. And then using EEG in terms of prognosis and sort of guiding our therapy with both short and long-term anti-seizure medication use is a bit unclear. So we're going to dive into some of the more recent studies and discuss some of those controversial topics and see kind of what we can do in the short term and then in terms of long-term follow-up. So the first study I wanted to review was an observational prospective study that was done, and it included 194 patients who had acute symptomatic seizures due to acute brain lesions. All of these patients underwent an EEG during their acute illness, and then they were followed up for up to 2 years. Only 85%, not all the patients were discharged on anti-seizure medication, so 85%, so we have to consider that in terms of the study, that not all the patients were discharged on anti-seizure medication, but most were. 29% had seizure recurrence in follow-up, and the mean time to onset of that seizure was 7.69 months. Now, this study was interesting, and you'll see the studies following that I'm going to present have some variable outcomes related to prognostication using acute EEG, but this study actually showed that epileptiform discharges on EEG was associated with a high risk of recurrence of seizures in long-term follow-up. They also found that presentation with status epilepticus was also associated with a high risk of recurrence of seizures. So this study was interesting in that looking at acute prognostication during the acute illness and then long-term follow-up to see how that played out. This study was a little bit different. So this focused on neuro-ICU patients that had acute symptomatic seizures, and they excluded patients with status epilepticus. In this study, most patients did have a structural cause, which is a bit of a confounder. They followed up patients for 12 months, and the median duration of anti-seizure medication use after discharge was 4 months. This study is a bit different than the other one. As you can see, there was a slight majority of patients discharged on anti-seizure medication. You also note that in terms of follow-up, less than 10% of patients had seizure relapse, and the relapse occurred at a median of 4.9 months after their discharge. Again, going back to what we talked about with structural causes, all of the patients with recurrent seizures had structural causes for their seizures. As opposed to the previous study, they did not find acute EEG to be helpful in terms of predicting the risk of recurrent seizures. And one thing to keep in mind, which has been consistently shown, was that the use of anti-seizure medications in the short term did not reduce the risk of long-term seizures. As you can see, 7 of those 11 patients actually were on anti-seizure medication at the time of their seizure recurrence. Now, if you look at the right, they have 2 diagrams that I found pretty useful and interesting, and sort of, pretty much show what they're trying to conclude from their study. Was that when you have a structural etiology, obviously the risk as you follow up is higher of having recurrence of seizures when compared to non-structural causes. And more specifically, what they found was that CNS infections with structural causes was an additive. Both of them were additive in terms of the risk of recurrence in long-term follow-up. So their conclusion was that having a structural lesion and having a CNS infection was associated with a high risk of seizure relapse. Now, I really like this study. This study kind of puts everything together. It looks at acute EEG and then also long-term follow-up in terms of how we use EEG to determine how we're going to use anti-seizure medications. So this was a retrospective study of 112 patients with clinical and/or electrographic acute symptomatic seizures on EEG monitoring. They were all discharged on anti-seizure medication as opposed to the other studies. They followed up for 12 months, and all the patients had an EEG during their admission, as well as in follow-up. They found similar numbers in terms of recurrence of seizures, with about 1/4 of them having seizures at their follow-up period and been diagnosed subsequently with epilepsy. What they found, interestingly, and I think this kind of elaborates why the acute EEG may not be consistently helpful, was that most of the patients that had acute EEG findings that were epileptiform showed in follow-up that those EEG findings resolved. So you can see 78% of those patients did not have those EEG findings at the repeat EEG in the outpatient setting. So they did these EEGs at roughly 3 months of follow-up, and what's interesting about the study, and again kind of highlights some controversies, is they had roughly half their patients undergoing prolonged ambulatory EEG monitoring and follow-up to help determine whether or not they were going to continue anti-seizure medications or they were going to discontinue those medications. They actually developed a scoring algorithm, which you can see here. In terms of predictors of epilepsy, what they found was that having persistent abnormalities on their EEG, of which 56% had that finding, as well as clinical as opposed to subclinical acute symptomatic seizures, and having a cortical finding on their imaging during their acute phase of their illness, were all associated with a higher risk of seizures in long-term follow-up. What I think is important from this score is that if you have a score of 0, the risk of having recurrent seizures is 0%. So I think this is a nice study in terms of putting that all together regarding acute phase and in terms of the workup and then in follow-up. Now, obviously, we're talking about a lot of variability in terms of the studies and what we're kind of finding and what the recommendations would be. So I think we also have to consider using sort of a survey and seeing what expert opinion is. And these are two studies that I really like that sent surveys out. The first study was actually an addendum to one of the studies that I just presented. This study was done in Germany. And what they did was they gave the physicians three different vignettes that were basically related to acute symptomatic seizures and how they would approach the use of anti-seizure medication. And then they also talked about unprovoked seizures in the case of a patient who had a TBI. So as you can see here, this diagram, it shows you the duration of anti-seizure medication use, with the left side being obviously no seizure medication use at all. It's represented by the white coloring. And as you get more darker in terms of the purple hue, you'll see that there's a longer period of time you have use of anti-seizure medication. And what you'll find is that the etiology was very important in terms of determining how they would approach the use of anti-seizure medications. So for instance, you can see here that patients who had acute symptomatic seizures from PRESS, as opposed to ischemic stroke, and then HSV encephalitis had differing durations of anti-seizure medication use, with patients being treated longer when they had encephalitis as opposed to the other etiologies. This is in contrast to having unprovoked seizures from a prior history of TBI, where you can see that the majority of practitioners would keep the patients on medication permanently, with less using medications in a shorter period of time. I also like the second survey that you can see here at the bottom, where they actually had done more of an international survey of physicians, and what they found was that as opposed to the first study you can see where they used acute EEG not as frequently, their study showed that acute EEG was strongly and heavily used in the acute setting to guide therapy. Now the interpretation of that EEG was a bit different, and one example would be using periodic patterns to determine how you would titrate anti-seizure medications was quite variable in terms of how it was interpreted, but acute EEG was still relied upon heavily. You could see also that in terms of the duration of anti-seizure medication use overall, and again, they didn't talk about etiologies, they just had a general view on the duration, that most were using it less than 6 months or up to 6 months, and then there were some stragglers that would use them for longer periods of time. But in general, 6 months seemed to be the cutoff where most practitioners were discontinuing medication if seizures had not recurred. What I found really interesting about this survey, and I think in clinical practice, I think at least in my practice, I actually rely heavily in follow-up on EEG and imaging. But in this study, only a third of the physicians actually used that to guide their therapy, which is interesting, considering especially the study that I just presented where they found that repeat EEG was pretty helpful in terms of determining whether or not those discharges were still there and then could help you guide long-term medication management. So something that I think we need to really study more given the variable degrees of use of longer EEG or longer anti-seizure medication as well as follow-up EEG studies. So if we put this all together in terms of just sort of a clinical, kind of some clinical pearls, when we have a patient who has a clear etiology that's reversible for their seizures, hyponatremia, sepsis, cefepime, these are patients that you would obviously want to reverse that cause. Now, if that cause is still going to be persistent or present for a period of time and there's a concern about the risk for seizures, short-term anti-seizure medication use is very reasonable. And I think in patients particularly that have lesions on their MRI, have a TBI, those are probably cases where you would want to start medication even without EEG or other studies to help guide your therapy. But we do know in terms of all the studies that acute use of medication is not going to reduce the risk of recurrence of seizures in long-term follow-up. Now, how do we use EEG to guide our therapies? This is a bit more tricky and a little bit nuanced. Obviously, in the acute setting, we're going to use it to detect or diagnose non-convulsive seizures and subtle seizures, especially if we're worried about non-convulsive status. In terms of acute management, if you're on the fence about starting medication, EEG may be helpful because if you see interictal discharges, that may help guide your use in the short term. Now, in terms of long-term follow-up, this is a little bit trickier. Number one, should we use EEG? And then if we're going to use EEG to guide it, how long of a duration of monitoring? And I think if you look at the studies on unprovoked seizures, it's pretty clear that ambulatory EEG monitoring is much more sensitive in detecting interictal activity as opposed to your 30 to 60-minute routine EEG. So if you extrapolate that to this, maybe we should be using longer EEG monitoring and follow-up if we're not sure about continuing medications. But that's not been systematically studied. And I kind of followed up with this on the long-term management. So these are some pearls I would keep in mind. And it really requires individualization, especially because there's not a lot of studies looking at how we go about managing these patients in the long-term outpatient follow-up. I think in general, we all want to avoid over-medicating. Obviously, there's a lot of risk with using these medications, particularly with adverse effects. And then in some cases, a good example would be phenytoin in stroke. It can actually worsen outcomes. So I would say that if you're going to keep patients on medications at discharge, you shouldn't be following up with them later than 3 to 6 months after to determine whether or not they need medication and long-term follow-up. Now, on the other hand, if someone has non-lesional case and there's a reversible cause, you would want to be more hesitant in terms of using medications in a long-term follow-up and have some sort of a plan to get them off medication sooner rather than later to avoid those adverse effects. And again, as I already alluded to, outpatient EEG follow-up, this is a tricky one because it's not been systematically studied, but as you can see, at least in some of the studies that I presented, outpatient follow-up with the EEG can be helpful in determining how long you're going to keep patients on anti-seizure medications. Okay, let's move on to status epilepticus. So we're going to discuss convulsive status epilepticus and non-convulsive status epilepticus. Obviously, there's a lot of different types of status epilepticus, but these are the two that we're going to focus on, given that these are sort of the most common that we encounter, as well as have some pretty clear guidelines that we can follow. So when we define convulsive status epilepticus, it's defined by having a seizure that lasts greater than or equal to 5 minutes, or having 2 seizures between which there's no full recovery of consciousness. We also want to define refractoriness because this is obviously important when we talk about outpatient or outcomes, but also we have studies that have been targeted specifically to treating these populations. So being refractory means that you failed the first and second line medication, which we'll briefly talk about in the next few slides. This would be a benzodiazepine and an anti-seizure medication. Super refractoriness is when patients have status that persists despite the use of anesthesia for at least 24 hours. And you could have patients who are treated with anesthesia that they're continuing to seize, or they're placed on anesthesia, the seizures briefly stop but then recur during that period of time, or you've put them on anesthesia, you've sedated them, they've stopped seizing, you reduce the anesthesia, and they start to seize again. So that would be the criteria for super refractoriness. Again, these patients have much worse outcomes, and it's very important that we define them. So when we are thinking about how we manage convulsive status, obviously the first line is going to be an IV benzodiazepine. Obviously, if you don't have an IV available, intramuscular midazolam is an appropriate treatment. We want to give it sooner rather than later. And over the last few years, there have been a number of studies looking at the use of benzodiazepines. And obviously, when we think about delaying treatment, this can really impact outcomes, particularly with the increased risk of going into a refractory status if we're not aggressive up front. And we know that if we are delaying treatment, it's going to lead to higher rates of refractoriness. It's going to lead to more intensive care unit admissions. And we also know that in multiple studies it's been shown that using higher doses of benzodiazepines and being aggressive up front for convulsive status does not worsen outcome, particularly related to respiratory distress and respiratory failure. So obviously we want to treat the seizures because that in of itself is going to put them at risk for needing to be intubated and sedated. So, and this has been something that's been harped upon quite a bit in the literature. So hopefully this is something that we won't be running into as much in the future. Now when we think about second-line agents, there are 3 drugs that we now have that have very good evidence for. This is from the ESET trial in 2019, and the doses are obviously very clearly laid out here, with maximum doses also laid out. And then your third-line agents are going to be medications that we don't have as much data on, or in the case of phenobarbital, the adverse effects are pretty high. Though it is an effective treatment, we kind of reserve that for a third-line treatment option. Now, I did want to present an update on ganaxolone. So I think most of us are familiar with this study. So this is the RAISE trial. It was looking at an allopregnanolone analog, and this was indicated for treatment of refractory status. So this study had 2 co-primary endpoints. The first was stopping status within 30 minutes, which it met that co-primary endpoint. However, unfortunately, it did not show benefit in preventing progression to IV anesthesia. Now, this is probably because there's a significant confound regarding the baseline characteristics of the ganaxolone group when compared to placebo. So you can see here that the patients with ganaxolone had higher rates of stupor and coma, so they were much sicker. They had worse severity scores with their baseline status epilepticus severity score, and their comorbidities were worse in terms of basically putting them at risk for having to progress to anesthesia related to treatment. There's also quite late enrollment, as you can see, average of 38 hours after onset of status. So I still think this drug is going to have a benefit for us and use for us, but there were some confounders, as you can see. The one thing I wanted to point out, too, which was interesting with this study, that most studies did not do this in the past, they used continuous EEG monitoring to not only diagnose, obviously we're diagnosing clinical seizures, but to also look at the effect on subclinical or subtle seizures, and there was a significant median reduction of seizures when compared to placebo. Okay, let's move on to non-convulsive status. So this is a little trickier condition that we all know about and we treat pretty regularly. So we rest this upon the Salzburg criteria. And obviously, we know that if patients have periodic patterns with frequencies above 2.5 hertz, That's status, and we don't need to really think much more other than treating those patients. We all know, obviously, that when we get the EEG, that's not always clear-cut, and it's usually more of a gray area where we have these periodic and rhythmic patterns that don't necessarily meet the definitive diagnosis of non-convulsive status. So in those situations, we're stuck with basically part 1. Obviously, part 2 and 3, that would also make the diagnosis of status if we encounter those, but we're going to focus on part 1, looking at EEG and clinical improvement with anti-seizure medication treatment. Now, the questions that we've been raising, we've all run into is, number 1, can we use an anti-seizure medication as opposed to a benzodiazepine, right? Because some of our patients are ill, and we're a bit worried if we oversedate them, we could actually end up having to intubate them, and some of these patients are quite frail. So could we get away with just using anti-seizure medication as opposed to benzodiazepine? What's the dosing that we should be using? Should we be using the convulsive status dosing, or should we be using a different dosing regimen? And then what's a clinical response, right? What does it mean the patient has to get up and kind of like, hey, thanks doc, thanks for saving me, I'm good, I'm going to leave now? I mean, obviously that's not going to happen because people are pretty sick. So how much of improvement should we really be seeing that we can say, okay, we got a clinical response, we know its status, we're good, let's keep monitoring. And then how long do we monitor before we say, okay, look, we've treated them, they're not getting better, this is not status? So this was a very nice paper that came out a couple years ago. It was expert consensus and using a Delphi process. And they gave recommendations for diagnostic and management intervention for non-convulsive status. They also talked about using benzos and non-benzos, and specifically laid out which non-benzos are preferred. It also talked about how do we administer these meds under supervision, both with EEG and clinical monitoring, and give us a very nice dosing protocol and algorithm. You can see here on the right, this is the algorithm. I'm going to kind of dive into it a little more deeply, but you have obviously your non-benzo pathway, which is on the right, and then your benzo pathway, which is on the left. So you can kind of choose your own adventure. So when we think about dosing with benzos, we want to give this every 2 to 3 minutes up to the max dose, and you'll notice that the doses are much lower than in convulsive status, right? And I highlighted midazolam because technically that is the preferred treatment because it has a quicker onset and shorter half-life. There's also the maximum doses given here both as a weight-based and absolute value. So this can help us guide our management and intervention with using benzos. When we think about anti-seizure medication, so we're not going to have to use that large full dose that we would typically use with convulsive status. So these patients can get 2/3 to 3/4 of the maximum dose, and we're going to monitor them for 15 minutes, clinically and on EEG. Now, if we have to use phenytoin or phenobarb, which is not the preferred treatments, we would have to use monitoring for 30 minutes. And what you'll see on the right is that there's the fast 4. So this would include levetiracetam, valproic acid, lacosamide, and brivaracetam. These are the preferred treatments for non-convulsive status. And obviously, if you have to and you don't have those available, phosphate is a reasonable option. Now, you can monitor them for 15 minutes, and if you don't see a response, you're going to, you can actually then end up completing that full dose, and then you're going to monitor for another 30 to 60 minutes to see if there's any clinical response or EEG change. Now let's expand more on this responsiveness. So what does that mean? So when we talk about clinical responsiveness, you actually only have to have an improvement on 1 point on the non-convulsive status response scale. So this is a very nice way to kind of conceptualize how we talk about responsiveness. And they laid out a very nice sort of leveling of more severe illness at level 1 and less severe illness at level 10. So if you see an improvement by one level, that's diagnostic from a clinical perspective. Now, when we think about EEG, it's a little bit different, so it depends on the EEG. So if you have a periodic pattern that's consistent throughout the recording, there's no break, you have to have resolution of that waveform or that pattern for at least 1 minute. However, if there's a break in that EEG study of greater than 1 minute, so 1 minute, 2 minutes, 3 minutes, you'd have to multiply that by 3 to then say, okay, so if I have a break in the action that's 2 minutes, if I give the medication, that waveform has to go away for 6 minutes before I can say that was diagnostic. There are also a couple other nuances. So these are patients that are comatose. If we talk about non-comatose patients, we actually would expect a more significant improvement in the EEG. So the EEG shouldn't just be the EEG pattern goes away and all is good. One good example would be triphasic waves. You give a benzo and it goes away. Does that mean that it was actually status? That's controversial. And I'm not going to get into that. But suffice to say, I've had those discussions with people, and it's very controversial. So if you have a patient who's altered and they're not comatose, they should have a pretty significant change in their EEG. I mean, it should be mild. You should maybe see a posterior rhythm. You should probably see some sleep structures. So there shouldn't be this, obviously clinically there may not be such a significant change, but the EEG should change drastically if they're not comatose. Just something to keep in mind. But again, there's a lot of variability and a lot of confounders there regarding clinical situations that would help determine how you're going to intervene and define a response on EEG. Okay, I promise we're almost done. We're going to go to seizure clusters. So this is the problem with seizure clusters. So the consensus definition is lacking. So we did a survey of experts looking at what do you call a seizure cluster, right? Because if you see those 3 bullet points, this is what the studies previously in the literature would tell you would be a seizure cluster. So having 2 or more seizures in close temporal proximity, having 2 seizures within 24 hours, or having a change in pattern of seizures within a certain period. That's pretty vague. And yet we have drugs that are FDA approved for seizure clusters, which is pretty weird. But suffice to say, this is a problem. And if you look at the expert opinions, it also had a lot of variability. So it ranges anywhere from 2 seizures in an hour to 3 seizures in 24 hours. So why is this important? It's because these are urgencies, and we want to intervene, so we really need to define these a bit better. And this is something that unfortunately is a problem in the literature, and hopefully we'll be able to sort that out with increasing studies and expert opinions. But we know that this will lead to an increased risk of escalation of seizures, and potentially patients can go into status if they start having clusters of seizures. We also know there's an increased risk of going to the emergency room and being hospitalized. So that's why we want to intervene, because we want to prevent it from getting to that point. So historically, we were using rectal benzodiazepines for prolonged seizures and obviously for seizure clusters, which is clearly not convenient, and particularly in adult patients, it's not the ideal situation. Now, buccal and oral disintegrating benzos were a little bit better. This was mainly used in Europe, though we have adopted that here and has been used, and obviously I think a lot of us have experienced some benefits with that. But I think the advent of intranasal benzodiazepines has really changed our management, and I think really a lot more patients are being willing to use these medications and are now FDA approved to treat seizure clusters. So we have 2 options. We have diazepam, which in those studies, what they found was that the bioavailability was similar, comparing it to the rectal gel. There was phase 3 open label and post-hoc subgroup analyses, and those studies, what they found was that those patients responded really well. So you can see only 12.6% of cases required the second dose to stop the cluster. And there's no tolerance to treatment over time, which is also really good. The other part of that study, what they looked at was, this was a little bit off-label because obviously these are FDA approved for clusters, but I can tell you, I'm sure Dr. Feisty could tell you, and all the epilepsy docs here, that we do use this. Technically, we tell patients to use it within 2 to 3 minutes of a seizure because obviously that's the best we can do, and we obviously don't want them to go into status. So if we can at all prevent that, we're going to try. But that's an off-label use. That's not something that's FDA approved. But what they found was that if you use it sooner, earlier in the phase of the seizure, it's going to be more effective. So if you dose it within 5 minutes, the seizures would stop within 2 minutes. And that was the median time to termination. If you dosed it at 5 minutes or after 5 minutes, the median time to seizure termination was 10 minutes. Again, this makes sense. Obviously, we all know the pathophysiology behind early use of benzos, and this just sort of is supporting that pathophysiology. And again, as we talked about before, the risk of cardiorespiratory depression is very low with using these drugs, and treatment-emergent adverse events were more likely when patients were already on a benzo. So something that you want to counsel your patients. If they're taking clobazam or clonazepam, they're more likely to have these adverse effects. Midazolam is the other option we have, and this study, as you'll see, and we'll talk about this in a second, the population was a little bit different. They didn't have as young of patients as the diazepam study, but what they did was they looked at primary endpoints, including termination of seizures within 10 minutes, and then no recurrence of seizures up to 6 hours, and both of those endpoints were met. When they did the open label extension, what they found was that, again, there was no tolerance to this drug, there were no treatment-related respiratory depression, and the most common side effects included nasal discomfort and somnolence. Dysgeusia is also something that you'll run into with these medications with your patients. So in terms of the indications and dosing, so diazepam, you can use it in patients greater than 6 years of age due to the studies that were done. And the dosing is weight and age-based. The difference between diazepam and midazolam is actually also how frequently or how early you can use it again. So in these cases, you're supposed to wait at least 4 hours before you would dose it again if necessary. When we think about intranasal midazolam, these patients are a little bit older in terms of the indication. This is not weight or age-based. This is a standard dose of 5 milligrams, and it can be given again after 10 minutes if needed. Now, the problem with these drugs, as with every drug that's new, is the cost. And a lot of patients will tell you that this is a problem. There are some, I believe the pharmaceutical companies do have some programs, but hopefully over time this will become something that's not as cost of an issue for our patients, because obviously it's very helpful and useful treatment, and we obviously want to intervene with these patients. So one thing to keep in mind, and we found this in our survey, and obviously we have a mixed group here in the audience, we're seeing this as well, I think, as epilepsy doctors, that these meds aren't really being used as much in the community, again, I can't speak to your experiences, but I think in our survey we found that physicians who see patients in the EMU particularly, these patients often come without these medications on board, and I think if patients are at risk for having clusters or they have tonic-clonic seizures, certainly these medications should be provided to the patients to prevent those from happening. And then last but not least, there's a new kid on the block, so this is exciting. So we have something that's going to be probably available in the near future. So alprazolam, so it's obviously a little bit different in terms of the way that it's administered, but it has a shorter half-life and quicker time to onset and peak. So this is actually indicated for prolonged seizures as opposed to the seizure clusters with the others. Now, the thing about this drug is that the enrollment has been a bit difficult, and if any of you are familiar with the study, the inclusion criteria are a bit cumbersome. But we are now at the phase 3, so hopefully we'll have more data to present to you guys in the future. And having more of these options is always going to be good for our patients. And that's all I got. Thank you.